Well, good afternoon, everybody. I want to thank you for coming to the first Dean's Lecture of the year. And as you probably know, we use these events primarily to recognize people who are either promoted or appointed as professor in our school. And we're here today to recognize Joe Gallo, who came to us from the University of Pennsylvania, where he was professor of medicine in the Department of Family Practice. Came here last year to join our faculty. And Joe is no stranger to Hopkins. Joe went to Fordham undergraduate, where he was a chemistry major. Then he went to Hershey, to Penn State, to get his MD degree. Then he trained in family practice. And then he came here and did a master's degree in the Department of Mental Health and came on the faculty. And 12 years ago had the poor judgment to leave, go to Penn, but we were able to get him to come back. No, I'm just joking. Penn is a wonderful place. It's my alma mater. And this. And we were very fortunate to get Joe to come back and join the Department of Mental Health. And Joe's, in many ways, a very unusual person. He's a physician who is trained in geriatrics and has written clinical textbooks about geriatric medicine, but on the other hand is a very quantitative researcher as well. And his work really runs the gamut of a whole variety of topics, but I would say, one of his primary interests is primary care, from his background as a family doc, and how we take care of people with mental illness in primary care settings. And so Joe, I first met Joe when I was in the School of Medicine, and he was an assistant professor here. And it was soon after that he left to go to Penn. But there was no causal connection there, I think. But we were happy, as I say, happy to get him back. And so Joe was recruited to the back to the Department of Mental Health, which he knew well, and to really lead the department in terms of primary care and health service research for mental illness. Joe also has assumed directorship of the precursor study. This is a study that started in 1946 and entered classes in 1948 to 64 of School of Medicine students, a cohort of 1,300 that have been followed now ever since, and average age is in the mid-80s, so offers lots of opportunity for aging, and as well as looking at mental illness. So Joe's going to tell us about his work. I see that he's provided this picture. Did you take this picture? No, okay. Has this picture of a blue jay as a symbol of his return to Hopkins. It's like you're the blue jay who flew home, right? So please. And I should just say about recognizing contributions. I think to come on the faculty here at Hopkins is a great accomplishment. And I tend to be jaded and cynical about accomplishments in life, but I have to say that being promoted to professor here is really a big deal. And it's a decision, for those of you who don't know how the decision works, it's really a decision made by people outside the university. So when somebody comes up for promotion, there's a letter written by their chair, but then we send out to all around the world to ask people in the same field what they think of this person's accomplishments. So the decision is really an affirmation by your peers around the world, many of whom who don't know you, about your body of work. And certainly, Joe, your letters were exemplary. So we're really happy to have you back here at Hopkins. So, Joe Gallo.
Hi, everybody. Thanks for the nice turnout. I'm very, very grateful to Mike, not only to be here to talk to you, but to be here at Hopkins. And what I wanted to do today was kind of give you a taste of mixed methods and talk, if I could, about some examples of mixed methods projects that I've been involved with as a way of talking about it. It's hard not to show you the slides about the history aspects. I'm assuming everybody knows who these four people are, but it's Welch that I really wanted to highlight because he was really visionary and could really think across fields and disciplines. One of the people he hired first was Elmer McCullum, who was feeding taxpayer money to rats in Wisconsin. But Welch realized that what he was doing in nutrition with rats could be applied to humans. One of the other people that Welch brought here was Adolf Meyer, who who was a psychiatrist, to talk about mental health and public health. And Meyer really thought about it very broadly in kind of a public health way. And I think some of his ideas really have come back to them because of the need to figure out how to deliver treatments that people will accept and have more effectiveness at a public health level. So what I wanted to do was go through quickly and talk about what are mixed methods, give a hint of why you would want to mix methods, talk about some designs in mixed methods, and then the practice and translation for mixed methods. So what are mixed methods? Well, when you talk about mixed methods, you can get one of two responses. People say, I've been doing that for years, or indeed, up until 10 or so years ago, people would say you can't mix methods because the presuppositions that quantitative researchers and qualitative researchers make are not compatible with each other. Some people talk about mixed methods with small m, meaning the idea that people have been doing it. And you can read some of James Trossel's work. He talks about epidemiology and anthropology collaborating 100 years ago. But now you could think about capital M mixed methods because there's a journal, there are textbooks, there's an NIH work group on mixed methods. PCORI may be very interested in mixed methods, and there are study sections, one of which I'm on, which actually we see a lot of mixed methods proposals. Some of them done better than others. But you can read a lot of education research and some early work in sociology talked about mixed methods, linking data from sociology. But more recently, Jan Morse in nursing has talked about mixing methods, and John Creswell, who was here at the beginning of the year doing a dean's lecture in the nursing school, actually, and Abbas Tashikori, both in education, have talked a lot about mixed methods. So there's a journal, there are textbooks, these are Creswell's textbooks. These are good places to begin. And also Tashikori's textbook, the second edition of which we contributed a chapter about writing mixed methods papers and proposals. But from Vicki Plano-Clark's paper, where she just looked at mixed methods, so it's an underestimate because she's not searching on qualitative and quantitative. These are the number of dissertations expanding that are called mixed methods, the number of proposals to NIH. And it has led to a set of practice guidelines around mixed methods, which if you're interested in this area, I would really encourage you to look at. Their definition of mixed methods is as good as any, and people have written papers about what does it mean to mix methods. But it's research that has really context as key. It's rigorous, quantitative, and qualitative, uses multiple methods, it's intentional, and it frames the investigation within philosophical and theoretical foundations. Now, this is E.T. It's the movie E.T. If you haven't seen it, it's a good movie. It's about a boy who befriends an alien. And to watch that movie and enjoy that movie, you have to suspend, your assumptions about reality and what happens. And I think when you think about across the disciplines and the quantitative, qualitative idea, you have to be willing to question the assumptions that your own discipline and your own training sometimes has made. So typically, and we use these terms, quantitative and qualitative, they're just handles for something more. But generally, quantitative means that you can separate the investigator from what's being investigated. It's value-free. The idea is to generalize beyond the context you're working in, and often involves large sample sizes and the data or numbers that you treat with statistics. Qualitative, on the other hand, is the idea that there might be sort of realities or ways people look at the world that are different from your own. That the investigator, in a way, is the instrument for the research. And there's a recognition of what we study and how we study it is mixed with the values that we have. Often the samples are small, and the data often is text. But what I wanted to just show, I'm going to use those terms. I'm not smart enough to think of it in a different way, but I do think it's important to think about where they're coming from, if you will. So if you take something like latent class model, on the face of it, you'd say it's quantitative. It's a statistical model that you're looking at patterning, say, of symptoms or characteristics in a population. But in a sense, it's also exploratory. You're specifying how many classes you think will there, and then the mixtures kind of emerge from the data. On the other hand, cultural consensus analysis is a method that is essentially like factor analyzing people in a sample. You want to know what's the construct that people have of depression, and I get a list from everybody in the room. And now, instead of analyzing the list like factor analysis, I'm reversing that, and I'm analyzing you all as items. And so then I can look at how much agreement there is. So it's very quantitative in that sense, but it's qualitative in the sense that I'm deriving the items from the people who are participating in the research. So I'm going to show you some designs, mixed methods designs, but I think this quote is important because you want to map the methods you use to the question that you're asking and what you're going to do with the information once you get it. So why mixed methods? I'm going to be very brief, and just to say this is an example from work of a colleague in my department, Judy Bass, who does a lot of international work, global work on mental health. And it's just an example showing a qualitative phase followed by a quantitative phase, deriving ideas from the people who you're working with or you're studying to come up with survey and interviews. But I would say that you don't have to go to other countries to find culture, if you will. And when I was here before, we worked a lot with the ECA data on depression in older people. Depression may express itself differently. And I was curious at that time, when you read about it, what do anthropologists who study culture, how do they approach it? They didn't approach it with the quantitative methods. But one advantage of having been at Penn for 10 years is interacting with living, breathing anthropologists, which is different from reading. So we have this notion that depression is different. And why mixed methods? Well, if you look at people with major depression who meet criteria for major depression and should have treatment, the rates are not changing, particularly among minorities. People don't use the treatment that's available. Jin Chu, who I've worked with at Penn, who's now at Hopkins, looked within a depression trial where psychotherapy is offered in the primary care practice to people who meet criteria for disorder, and you see a disparity between white patients and African Americans. So despite the progress that's been made, people still don't get treatment, especially minorities. And older adults don't seem to accept what they say they want, which is someone to talk to. And so what I wanted to do, so I think those are reasons, the potential of mixed methods, rather than kind of continuing to do what we've been doing and come up with different ways to think about offering treatment. I'll show you, I hope, some examples. So in terms of designs, you could think of mixed methods designs in a lot of different ways. But one way people think of it is connect, merge, or embed. So connect, I'll show you some examples. Usually there's a sequential aspect to it. Merging means you have two strands that may occur concurrently, and they're mixed at different stages of the research. Embedded means there might be, say, a qualitative component inside of a larger quantitative study. So this may be a typical example that's used for, let's say, developing an instrument, very much like Judy Bass's study. There's a qualitative part followed up with a quantitative part. Now, not to simplify it too much or take this too seriously, but sometimes people think of mixing methods, or what the qualitative component has, is only to help you design an instrument from which then the real research can happen. And so what I want to do is show you some other designs and kind of help you think more broadly with the designs and showing you some examples. So we could reverse the sequence and have a quantitative component followed by an explanatory qualitative component. We could have two strands that are occurring and then converge, where we're comparing results, if you will, from the strands. And sometimes what's done is to create this matrix where you've got variables down the rows, and you're looking at themes that emerged from looking at text data. And I'll show you an example. Or they could be embedded, either a qualitative study that gets some, say, descriptive data that's quantitative, or a quantitative study that incorporates some qualitative data collection. So I want to show you some examples of studies that I've been involved with that involve mixed methods, to give you a flavor of the kinds of ways it gets carried out. So there are 6 studies, and I'm going to just really briefly describe them. I can't go into all of the findings or publications for all of them, but I wanted to start with the spectrum of depression in late life. That was 3 linked RO1s. And the 3 linked RO1s roughly had these questions. What is a symptom cluster that might be like depression but doesn't meet standard criteria for depression? How does that map to ApoE? And how is depression experienced by older people? And so this first part was, these were 2 RO1s for these 2 aims, involved screening patients in primary care practices. We came up with a sample of 355 who were interviewed in their homes with standardized questionnaires. And so the idea was to look at depression in relation to standard instruments and criteria. But we also had dynamic sampling to do semi-structured interviews for 100 people, 50% white, 50% African American. This is in Baltimore, by the way. And the semi-structured interviews basically had 3 components: vignettes for people to react to. The vignettes were descriptions of people who might be depressed, but it doesn't say they're depressed. The second part is free listing and pile sorting to get at the construct of depression that older people have. And the third part was an open-ended interview about what you think depression is, what causes it, what do you do about it. But we also made a deliberate effort to link these pieces. And so there are some publications that are sort of purely quantitative or purely qualitative, and then there's some that are mixed. So this is really a convergent parallel design. So the kinds of research questions we ask that might be considered mixed. What's the meaning of bad nerves? People brought up A third of the 100 people brought up nerves when they were talking about their emotions. Do patients whose doctors identify them as depressed talk differently about depression? How do older adults and their primary care providers overlap and diverge in their ideas about depression? So there are a number of papers around those kinds of topics. One, which if you're interested in the mixed methods design and rationale for spectrum, it would be in this bottom paper in the Journals of Gerontology. And there, I won't dwell on it too much, but basically the paper tries to use 3 strands or strategies to get at the construct of depression that older people have. And I'm not highlighting it in the slide, but there were some differences across ethnic groups. So, for example, older African Americans were more likely to say they were lonely, but in terms of their construct and what they thought the relationship of loneliness was to depression was very similar with white patients. But you can see we're using consensus analysis, grounded theory, and some statistical analysis to tell a story in that paper. An example of using a matrix like this is a paper that Marcia Whitting did, where she looked at patients where the doctor rated them as depressed or didn't rate them as depressed and compared them. Didn't find very many differences, although patients that the doctor rated as depressed tended to be a little younger, like 73 versus 77. Then she also analyzed the interviews for themes, which I'll show you, and then compared those groups in terms of the characteristics like age, etc. And so it looked like there were 4 themes that people talked about when they talk about their relationship with the doctor. They say, my doctor just picked it up. They knew it when I walked into the room. I was trying to tell him how I was struggling. He said, you're depressed. Another type was, I'm a good patient. So these are people who, the doctor thinks they're doing well. They schmooze with the receptionist, this kind of thing. They just check out your heart and things. So those are people where they didn't talk about their feelings. It wasn't on the table with the relationship that they had. And lastly, they'll just send you to a psychiatrist. So the fear that if you talk about it too much, the doctor isn't going to help you deal with it. They're going to send you to a psychiatrist. And when you look at those themes and now go back to comparison, you can find some interesting things that are discussed in the paper. So they just check out your heart and things. Those are people who say they don't discuss emotions with their doctor. So that's really just a taste of spectrum. Another is Sue Yan Lee. This is a doctoral dissertation that's completed, and which I'll tell you about. I don't know if Sue is here. Maybe not. So, but what Sue did was she took some of the interview guides we used in Spectrum and applied it to this sample of older Korean Americans living around Baltimore to do a mixed methods project. And she had 3 aims: the prevalence of depression, other disturbances in Asian Americans. Are there subtypes of depression? And why don't Korean Americans with depression and death ideation use mental health services? And so each aim has a component. She used national data to derive prevalence estimates, make inferences about rates. She used quantitative data to use a latent class model to look at subtypes across the groups. And then she has this kind of explanatory design where with a different data set, she's looking then to select people from the larger data set to focus in on people who have a lot of depression but may not be using services. So it's an example of connecting the quantitative and qualitative with that last aim. So the memory and aging study of Koreans in Maryland was the basis for doing a quantitative analysis. And the upshot of it is a lot of people had depressive symptoms, but very few used mental health services. They also had death ideation, but very few used mental health services. So the idea was to then pick a smaller sample to try to get a better understanding of that. And I know she's working on that, but some of the preliminary ideas are around negative views on meaning of depression, and also talking about family and social conflict, and this idea that they didn't realize the American dream, and that's why they have depression. And also talked about lack of counseling support, financial means. Oops. So Jin Ju is a psychiatrist who, in Philadelphia, did a pilot study where she worked with peers, older people, who would be able to reach out to older people with depression who otherwise might not use services. And what she did was she audio taped those interactions, listened to them, and then fed back training to the peer. So it was just kind of a proof of concept idea. Now she has a K award under review, and I just want to show you a little bit about the design, the mixed methods design of that K. So this peer mentor role would have kind of assistance navigating services, reaching somebody by being somebody who's similar to the person that you're trying to reach, but also provide emotional support and maybe even something like psychotherapy. She's supervising them in a way to do psychotherapy with older patients, older persons. And so this is an example, will be an example of an embedded design to develop the intervention. Now, well, maybe you can see that from the back of the room. You know how when people put up a slide with small print and they say, I'm sorry if you can't see that in the back of the room. But actually, it's good if you can't see it in the back of the room because there's too much detail. What I wanted to show you was that in the grant, or when you're proposing a mixed methods design, I think it's helpful to have a table. And actually, the working group for NIH uses a table like this that came from Spectrum as an example. But what the columns are the aim, the data source, the analysis, and the goal. And what it's meant to be is a roadmap to the reviewer. So as they go down and read the rest of the research and analytic plan, they've already been exposed to what the overall strategy is going to be. And in Jin's case, there are quantitative components in green here, and there are qualitative components for each aim. So the first aim is about feasibility and acceptability of the intervention. So if we just looked at the green here, there are measures at the beginning, predictors, and then through the intervention, looking at depression and engagement with the peer as outcomes. But it doesn't stop there because with intervention development, the idea of having these debriefing interviews and then analyzing that text data to get a better understanding of what the processes are. So it's embedded because we're looking at quantitative data, but there's a qualitative piece in there. So the quantitative part would be to identify factors related to outcome, and the qualitative to look at what are the processes of the intervention so that you could design a better intervention. In the second aim, with those recordings, she's proposed to use Deborah Roeder's system to quantify the utterances, essentially. Using Deborah Roeder's system lets you see how much time are they spending asking questions about building rapport or giving advice and so on. And the idea, and there is a little bit of evidence from the literature, the specific behaviors of the peer may be related to the outcomes. But we also want to take the interaction data and analyze that thematically to get a sense of how does the intervention work? What are the peers doing? So it's an example, again, of interactions associated with response, quantitative analysis, but also trying to capture with an open-ended analysis of the interactions. I hope it wasn't bad luck to talk about it. It's going to be reviewed probably in the next month or so. Marcia Wittink had a K23, which was an R34. She's now submitted an R01, using conjoint analysis. Conjoint analysis comes from marketing. And that's how companies figure out what kind of computer you would buy. Or if they changed a feature of a car, how much would their market share change? But the idea here was, can you use conjoint to figure out how to design treatments that would better map to how people think about what depression is and what you do about it? Let me see, and it's inherently a mixed methods design because it has a conjoint task with a quantitative analysis sandwiched. It doesn't have to be sandwiched, but the qualitative first, but often sandwiched between two qualitative components. Let me see if I can get it across to you using these color boxes. So the idea, what those boxes represent in A, that's a feature of a treatment. And hopefully you've derived it from what's important to people. So an example could be of those three boxes. A feature of treatment could be side effects you'd expect, or how many times you meet with a therapist, or who do you meet with, primary care doctor, minister, or a psychiatrist, or is this a treatment that you have to do on your own, you do homework, or involves a group? So it could be any of those, and then the colors are levels of the treatment. And so you could think of these columns like treatment packages. And what you do is you show people two treatment packages and they pick which one they'd prefer. And what's behind it, so you'd say this one, or this one. What's behind that then is a model that, depending on your field, you're estimating their weights, they're like regression weights, or their part worths, or their utilities, depending on the field. And then often, or there can be a qualitative component. So as people are doing the task, you're capturing what they're saying about making the decisions, or you talk with them after about the decisions that they make. And the idea is that, oh, sorry, I forgot this slide. So this is kind of summarizing it. You're playing off one attribute over another. That's how you really make decisions. If we just use Likert scales, you'd say cost. Everybody doesn't want, the lowest cost. But it's always in relation to what else you're getting. And that's where the conjoint task is supposed to be more like a real decision. Come up with the utilities, and you can create then profiles, latent classes or latent profiles based on those utilities. So I'm not going to go into the detail, but the schematic, the idea is, and she's called these values markers. I don't know if I should tell you the real story behind that, but in writing the grant, if you make these bars and things, they kind of look genetic or something, and so subconsciously we thought maybe if we called them values markers, that's more conducive to the reviewers. But basically, they're markers or profiles that presumably, if the treatment was better matched, you'd have a better result because people would uptake the treatment. And so that's an example of a mixed methods design. Implementing care for depression and diabetes, this is a merged design. So the idea here is that practices, primary care practices, are trying to implement components of the chronic care model. But rather than just thinking of that model is going to apply everywhere, the point here is that besides the intervention components, there are also implementation components that have to come into play to see the effects on patient outcomes. But different practices, it's the context again. Practices are different. They may implement things differently. They may pick some components more over others. And the idea here is to describe, using mixed methods, not just instrumentation in terms of what they're implementing, but also capturing through focus groups, getting narratives about the experience of trying to implement the chronic care model, the medical home, that then you could come up with a better set of advice through a manual, say, in the next stage of the research. So the next set of practices, you'd have a better sense of how to help them in terms of the implementation. And one of the things that Dr. Bogner had in the grant, which again I think is very important for these mixed methods designs, I think you see focus groups added to grants, that takes care of the qualitative component. Often it's not clear how the pieces are linked. And the idea of this table is to be very clear about what kinds of information might emerge from focus groups that then informs the intervention that comes out of it. And last but not least is the precursors project. I wanted to just give you a flavor of the design. It's an example of quantitative followed by qualitative with a twist, sort of. These are the aims. I won't read them. Basically, what they're talking about is changes in preferences for end-of-life care over time. In a sample of physicians, these were medical students at Hopkins between 1948 and 1964. Now many of them are in their 70s. So the first aim is about how preferences change with age over time. The second is, how do people think about those decisions? And the third is, what kinds of experiences did people have when they actually had to make end-of-life decisions? And so here again, it's okay if you can't see the print. It's the aims, the sample, the analytic strategies, and the goals in the column. Here, the first aim is quantitative. The other two aims are qualitative. And what we proposed to do was, let me show the picture. So what these represent, the bars represent latent classes of how aggressively you would want to be treated at the end of life, given a scenario. And so there are three classes where if you're in that class, you're reporting that you would want all of the interventions virtually. CPR, mechanical ventilation, antibiotics, IV fluids. The third class is a class who doesn't want very much in that situation. The point here is to look at how are people changing their preference over time and what might be driving that. And what we wanted to do was that classifies the preferences into these packages rather than looking at individual preferences. And so what we want to do is use the latent class in two ways. So one is to study the transitions, but another is to use that as a sampling frame for purposive or informative sampling. So for example, by sampling people who are saying they don't want anything now, 3 years later or 6 years later, they want to be treated aggressively, and vice versa. And what we would do is then talk with them about what's their thinking behind end-of-life decision-making. So that would be the second aim. The third aim takes participants, family members who have died, and talks with them about the decision-making that was made at the end of life. So that would be a third aim. So there's a quantitative piece followed by two ethnographic samples to get at an understanding of end-of-life decision-making. So we essentially have quantitative and qualitative components for preferences and also for service use and the events around decision-making. So that's going to be resubmitted. So I'm sorry, it's a very whirlwind tour, but there are a lot of different ways that the methods could be mixed. Just a couple of comments about moving forward. I think where you are on the spectrum for effectiveness, implementation, dissemination, I think these methods are very important because you're in contexts or settings, communities, primary care, where it's very important to understand, not just to generalize to all primary care practices, but to understand how people make sense of their context, particularly for implementation, as the example I showed you. And also in interventions, mixed methods may come into play, not just for instrument development, but potentially for understanding recruiting strategies, how to modify the intervention, in between for understanding processes, fidelity, how an intervention is implemented, and then at the end for understanding outcomes, what kind of feedback could improve the intervention, and maybe even for understanding how mediators work. And we're doing a review to try to look at how mixed methods has been used for intervention design. Now, another good movie is Close Encounters of the Third Kind. And if you haven't seen the movie, maybe it won't make any sense, but all these people don't know why, but they're drawn to Devil's Tower in Wyoming. And the reason is aliens are calling them, but only a few make it, because the government, of course, puts up all these barriers to them. And I feel like it could be that way if you're trying to do mixed methods, like if you're a student, like who gets through, to Devil's Tower and actually carries it off. So, you think about doing interdisciplinary work, it can be very difficult, but fun. People have a different vocabulary, different training models, different ideas about what it is to be a research subject or an investigator. And I think it's really key. Maybe the last one is the key. The leader sets the tone. So it could be somebody, who doesn't know every single thing, every method, but is able to draw people together. You have to have a willingness to have a different perspective. It's like the ET idea. Surviving the kick in your epistemology. It does make you really think through what are the assumptions that your discipline is making. At the same time, disciplines are more than methods, right? They're communities of investigators, certain way you behave, certain way you get socialized. And for that reason, maybe it's important to think about big M mixed methods. What's a student to do? Actually, these 4 bullets came from a slide that Sue gave me, thinking about her dissertation, right? Helpful to form an interdisciplinary team. It's fun, rich information, but it can be challenging to think of drawing these pieces together. I think it really behooves thinking about what's the question, where you're going. We've talked about, or I've talked with some people at the school, at NIH, with John Creswell, about the idea about a training program. One form it could take is like a program that I'm already involved in for mental health, but not specific to mixed methods, is bringing scholars and people from around the country who then mentor people doing a project. And the other would be thinking through developing a course or courses that doesn't duplicate what's already here. And I didn't want to forget to mention, we do have a mixed methods interest group. It's the second Thursday of the month. I think it's room 188, but send me an email, if you want to come and you're not getting the emails that we're sending out. The next two actually going to be on the first Thursday because I moved it after we made the arrangements. But Robert Rubenstein from UMBC has done some very important work in aging. He's a medical anthropologist. Kara Zivin is someone that I've been working with as a mentor at the University of Michigan. She's proposing some services projects in the VA that use mixed methods. And she's going to be in Washington the next day. So she asked me if she could come, and she'll present. And then Lauren DiMicelli, who's here, has some mixed methods ideas. So we kind of want to use it as a working group, get some feedback, and mostly do what I really like to do, which is just have fun. So I'll stop now, and I want to thank you all, and I thank the investigators, Sue and Hillary and Marcia and Jin, for letting me show their slides. And I just hope it was helpful and not too confusing to see the designs. I think it is useful to think in terms of the designs, although I have to say, if the history of Spectrum, I'm not sure, was just the interaction we had with a nice team that developed that project. We did, the textbooks weren't there yet. So in a sense, it could be easier for people who want to do that now. But I'd be glad, I think there's like 10 or 15 minutes left for questions. It'd be great to have a discussion, or tell me you're doing it already and we don't need any more. But thank you so much. Yeah. I guess I should stay here.
Yeah, stay right there. So thank you, Joe. Great talk. I have mixed feelings about it.
Yeah, somehow I thought you would.
But so if anybody wants to make a comment or ask a question, I ask that you use the microphones because we're recording. And the question won't be recorded unless, we won't hear you on the podcast.
Oh, my email is here. Please contact me if you want to talk more, have coffee, whatever.
Yeah. So Joe, let me ask you.
Yeah.
In terms of when you submit grants, because you focused a lot on grants and funding.
Isn't that what you're supposed to do?
Yeah, well, that's you got the message. But I would think, is there a problem with acceptance by study sections? I mean, I could see if you don't have a study section with the expertise. So is that a challenge, and how do you deal with that?
Anything's a challenge now.
Yeah.
But I think it is important. That's always important to figure out who's reviewing it. That. But if you look at CSR, so for example, if you look at the description for the committee that I serve on, Community Influences on Health Behavior, and you look at that roster, there are geographers, statisticians, anthropologists. It's really interesting, and we do get mixed. You do see the mixed methods. They are discussed. They're not dismissed. But it has to be rigorous. And I was looking today, there are other committees that include mixed methods in the description. So anything's a challenge. But I think it is, I think reviewers like it when it's done well. I think what you see is when it's not done well, or it's an afterthought, or the pieces are not well linked. Reviewers do bring that up. They expect a certain rigor with it.
Thank you.
Does that answer your question?
No,
I mean,
that's good.
yeah.
That's good. Yeah. So, comments or questions? So, there may be somebody.
I'm curious in your review about how mixed methods are used to design interventions, how you're designing mixed methods. Are you only including things that are big M mixed methods?
No, I forget no, it's going to, so we include terms like qualitative and quantitative. So it's together. So it's different from the curves I showed Vicki Plano Clark, because I talked with her. I know that she just looked at studies and dissertations that identified themselves as mixed methods. So we're trying not to do that.
So then as you're going through the literature, if you see something that looks like a good study, it looks rigorous, and it also is different than anything you've seen before, is that necessarily mixed methods, or is somebody just being creative in their study design?
It's like who's identifying it as mixed methods,
Well, I
me
never
or
would
them?
have guessed that conjoint is a mixed method, for example.
Oh,
I
I
would think of that
see.
as conjoint. But how do you start to identify mixed methods as you're going through the literature?
So what's your definition of mixed method?
Well, I think the definition is using quantitative and qualitative methodology in the same study. I mean, a trick can be that it may not be in the same paper, right? So, like our study, we published papers that, as a body of work, it's mixed, but there might be some papers you look at you wouldn't identify it as mixed methods. But I don't think that. So not all of the studies identify themselves as mixed.
Thank you.
Thank you very much. If I remember correctly, the title of your talk was something about mixed methods in research, teaching, and practice. I wanted to ask you about the third of those, practice. I guess I feel that mixed methods does have sort of some particular benefits when you're talking about translating research into practice. And I haven't been able to unravel it fully myself, but I guess my sense is, my gut feeling is that you're able not only, through mixed methods, you're able not only to, for example, demonstrate effectiveness, but also begin to explain why, and being able to investigate how interventions are really working in the field. And I think that then has greater sort of tangible use to policymakers and people deciding in practice. So I wondered if you could unpack that linkage.
Yeah. Well, frankly, I'm not sure I'm exactly there. That's really the leap. That is very, very important. So that may be, Jin's study, for example, with the peers, might be a good example of that, or Dr. Bogner's study with implementation, where really the next step will be to take what you learn there for the next step. But I think that's going to be very, very important. A lot of the emphasis on implementation seems like that's a very rich place for it. But I don't think there are, hundreds of studies that identify what you're talking about. I think that's an area that's up and coming.
Any other comments or questions? If not, we have a reception outside, and there'll be opportunities to talk to Joe one-on-one and follow up with questions there. So Joe, I want to thank you.
Again, thank you all for coming.